Hello, nursing graduate students. I thought that for this week, in our topic on middle range theory, I would record the lecture ahead of time so we have more time to do different activities in class. Just looking back, we'll go over some of the things we've talked about. We've talked about paradigms and the different ways that we develop knowledge, both in nursing and science in general. We've talked about theory in general, as well as nursing theories, looking at the context of our history, kind of why the nursing theories were developed to better explain what we were as a discipline as well as what we do in practice, where we are today with the nursing theories and going forward. And we looked at some models you might be able to use to frame your own practice and roles. We also talked about the nursing meta paradigm that Jackie Fawcett was the one who first articulated, and her definition is the one that's most commonly described, although there's certainly been others. And she described them as four broad concepts consisting of person, health, environment, and nursing. Okay, we looked at 20th century science and some of the changes in that, and how the discoveries in physics changed kind of how we did science, how we viewed it. We went from the mechanistic views of Newton and some of them to kind of the broader systems view, the views of Einstein and other things like that. Remember Thomas Kuhn? He's the one that talked about paradigm structures and kind of came up with the phrase of the paradigm shift. And he saw paradigms as the questions that are asked in a discipline, as a way in which we guide what we do research on, and that each discipline had a particular way of looking at things, and that's its paradigm. But it also can eliminate us from asking certain questions. And I think this is in a later slide also, but just as we saw that since the paradigm was that syphilis originated in the New World, that questions about it and maybe even some evidence wasn't seen because that wasn't within the existing paradigm. And again, it gives a worldview of the nature of reality, but sometimes you get so like enraptured, I guess, of that reality, you're not able to see that there might be other answers to things. Loudon had a little bit different view. He's another philosopher of science, and he said that the purpose of science is to solve problems, and theory tells us how to do it. He didn't look so much at paradigm. He talked about research traditions and how different fields have certain research traditions, and those are the assumptions within their discipline. And I found this cute little cartoon about the little bird who has this really big paradigm shift. But some of the paradigms that we've talked about in science were the positivists, that there is an absolute reality and science has to be done really strictly and you can't have any other variables. And I mean, it was even believed that human beings don't influence science or reality, but that was shown to not be true. So along came the post-positivists who say, well, okay, so we know that there is influence of human beings, but we're going to try to set up science and set up our experiments to minimize those as much as we can, because we're realists. We know that these things happen, and so we're going to make a science that takes that into account. But then there were the postmodernists, including constructivists, feminists, and critical theorists who say that, reality is how it's perceived by the individual. And if you want to find out about it, you talk to individuals. And so it really was an important part of qualitative research, is that it has a different paradigm approach. And I said on the previous slide that you remember the syphilis enigma and how the paradigms of science really changed in that. So, why do we even study knowledge? Well, nurses are fundamentally knowledge workers. I know early on in our schooling that sometimes, especially when you're a brand new nurse, it feels like we're skill workers. And the scary thing is you got to know how to do the skills, because that's what we're going to go out there and do. But in actuality, we're really about knowledge. Skills change. Any of us who've been in nursing for a while can tell you how different things are from when we first started. I was talking to one of you in class, I think, where we, of course, all had to count the IV drips because we didn't have the machines that the IVAX, or whatever the current name of it is, that would control the IV infusion. So you had to be really good at knowing, how to count how many drips per minute, and then really watching them, because sometimes the IV would get away from you, and you'd have all this fluid or whatever you didn't want in the patient all of a sudden. So it was a totally different skill, but the knowledge is still there. The knowledge of what the infusion's about, what fluid we're giving them, and all of those sorts of things. So we really are knowledge workers. I like Porter O'Grady's quote. He said, "Nurses synthesize a broad array of information and knowledge from a wide variety of sources and bring that synthesis to bear on nursing work." When we talked about nursing knowledge, we looked at Carper's four patterns. Remember, she had the four distinct ones: the empirical, which is more like the positivistic approach to science; the aesthetic knowing, which is our meaning and imagining and makes use of our intuition and empathy; the personal knowledge, knowledge of the concrete individual, the self; and the ethical, the knowledge of what's wrong and right, and our commitment to act on that basis. So Fawcett also contributed to what, oops, let's go back on that one, our views of knowledge, and she had a hierarchical view of theory going from the grand theories or meta paradigms, and I've kind of given you two different views of this hierarchy, to the conceptual models, to the mid-range theories, and then down to either empirical indicators, or some call them practice theories or micro theories. And yes, sometimes the names are different, so it just depends upon the author. And you have to look at how they're defining the different things. So let's look at middle range theory. It has been seen for a number of years, actually, as the next step in theory development. It's seen to be more closely linked with research and practice, and it helps us describe, explain, and predict phenomena. It is said to be more simple and straightforward, easier to understand and apply. And I hope, as you read the articles, that you found that they were more straightforward, and that they were closer to practice, and easier than some of the terms we got. Like if you had Roy last week or Rogers, they use very different terms, and the middle range theories don't tend to do that. So some examples of middle range theories are Benner's Novice to Expert; Kolbaka has the comfort theory; Morse, you read hers on suffering; maternal attainment and certainty, and many others. So they're said to be useful in research and practice. And nowadays, most nursing researchers have a conceptual or theoretical foundation for their work, and more are using the middle range theories for these. And it's believed to have a great potential for practice, but there's still that theory practice gap. It doesn't seem like they've been incorporated into practice as much. So the issue with middle range theories is when you define them, it's kind of, everybody talks about like where they are or what they're not. There isn't that specific definition of exactly what a middle range theory does. So they lie somewhere between the general and the very specific. Okay, so they're not at all. You can't say they're very generalized, and you can't say they're very particular. They're that in between place. It's the middle of a continuum. Okay, some of the controversy around it is, just as I said, there's imprecision in what constitutes a middle range theory. Because, again, the definition is it's not too broad, not too narrow, and somewhere in the middle. Thus the name. That makes it kind of hard to utilize when you're kind of looking for something that's just in the middle without the real specifics. Another more recent criticism is that as we get more and more middle range theories, is this going to lead to fragmentation of nursing knowledge? If you're looking at a particular patient and you're concerned about grieving and suffering and uncertainty and resilience, there's all these different things to choose from. Does that help us in our practice in knowing how to take care of the patient? And just, this isn't related, but some researchers believe we shouldn't use middle range theory from other disciplines. Not everyone, some people do. Okay, so I want to include this review of middle range theory. It's from 1999, but I did a literature search recently to try to see if there's something more up to date on this, and I can't find anything done of this scope. So when they looked in 1999, they looked back 10 years looking for what they could find about middle range theories in nursing. And so here we are, 15 years or more later, and I think there's still some applicability. They at this time found 22. If you go out there today, you'll probably find 4 or 5 times that many, if not more. They also found that some things were labeled middle range theory by others, and they didn't make a judgment on it. But like Orlando's, she's one of the nursing theorists. They said people have said she's middle range. Watson has been said to be middle range, as well as Peplau. I've even heard Oram described as a middle range theory sometimes. Okay, so what conclusions did they make? They found in 1999 that middle range theory is scholarly, that it was building upon the grand theory we had at the time, that they thought it was an integrated paradigm, and that it was focusing on our caring healing focus. This is a little bit in contradiction to the one that was afraid we were getting too fragmented with too many of them. And in the caring healing focus, they were finding things like the transcendence, resilience, nurse expressed empathy, things like that. So they believe that the future was to move nursing theory forward by continuing to develop middle range theory congruent with our historical and theoretical development. Okay, so what are some of the approaches to generating nursing range theory? There's the inductive theory building in research and practice, and Morse's article on suffering is a good example of that, using qualitative research and building theory from that research. The opposite would be deduction from research and practice and applications of grand theories. Okay, and some said we can combine existing nursing and non-nursing middle range theories. We'll talk about one in a minute. Okay, also deriving theories from other disciplines that are related to our disciplinary perspective. And, if you think about the things like on grief and dying and some of those things, we've certainly utilized those theories within nursing. Some say you can synthesize theories by looking at a variety of research findings, and others say you can derive them from practice guidelines and standards. Okay, but what are some examples? Okay, so this was one that actually started as a theory in another field, and Benner was interested in the Dreyfus model of skill acquisition, and she wanted to apply it to nursing. As I recall, this model was related to, I think, airplane pilots learning to be, as they kind of learn their profession. But if I'm wrong, somebody can correct me. And her area of concern wasn't how to do nursing, but rather how do nurses learn to do nursing. And from this, she developed the novice to expert model. Now, she also did qualitative research, asking nurses about this, and then integrated her findings with a model for skill acquisition, and made this theory that our model that we all use all the time now. It's been very widely tested and applied. The Morse theory of suffering is similar to the concept or the issues of comfort, and it addresses important issues in nursing. And it's derived from the qualitative research she did on suffering from the perspective of patients or the one suffering and her observations. Now, another way to look at deriving nursing middle range theory, and you don't see this very much, but I want to present it because it's a different idea, is using the nursing taxonomies. And the nursing taxonomies are nursing diagnosis, nursing intervention classification, and nursing outcome classification. Okay, well, what are taxonomies? Okay, well, they're just ways we classify information. So I use this as an example, these little group of pictures, and think about how would you classify them. You can look at them and you can see there's two broad categories of things or classifications. There's animals and fruit. So if we want to make a classification, we divide them up into the two categories of animals and fruit. It's a very simple taxonomy or classification. So the nursing taxonomies are nursing diagnosis, as I said, nursing intervention classification, NIC, and the nursing outcomes classification. Nursing diagnosis, they may also say NANDA, the North American Nursing Diagnosis Association. So, nursing diagnosis, I think most of you know that these are our clinical judgments about individual, family, or community responses to actual potential health problems and life processes. And they provide the basis for selecting the nursing interventions or a way to get the desired outcomes for our patients. The interventions are any treatment based upon clinical judgment and knowledge that a nurse performs to enhance the patient outcomes. You can see you've gone from the diagnosis, now you're going to intervene. They can be both direct and indirect, and they can be initiated by nurses or other healthcare providers. Okay, so you found the diagnosis, you did something, and the interventions are going to have a label, a definition, and a set of activities that you commonly carry out. The nursing outcomes, then, this is what happens after you've done the diagnosis and the intervention. It's a variable patient, I think it should be, or family caregiver state, condition, or perception responsive to nursing intervention. Okay, there's 200 outcomes that have been identified. There may be more now, and they're measurable indicators for each outcome. So again, there's a diagnosis, there's interventions you do, and then you look at an outcome. What happens to the patient after you've done those things? What are you trying to achieve? Okay, so the authors that looked at this suggest that concepts from NANDA, nursing diagnosis, NIC, and NOC be used to develop nursing middle range theories by linking these concepts. Okay, and they believe, or she believed, that the center of nursing knowledge was the relationship among these. So here's an example. So the nursing diagnosis would be activity intolerance. You can look at what the indicators are. The nursing intervention I put up too might be body mechanics for motion or energy management, and there's activities listed that you would do. And then the nursing outcome would be ambulating the patient, how well is the patient walking? And then there's things that you would look at. They're walking with an effective gait. They can now walk up and down stairs, things like that. So how do you get middle range theory out of this? So if you look at how these are connected, you might think something like that somebody with an activity tolerance, that you utilize energy management techniques, is going to have improved ambulation and balance afterwards. So they're saying that would become like a middle range theory, that you pull those things together and create a theory from the three of them. So just an idea. As I said, I don't think this has really caught fire, but it's kind of a different approach. So future directions now. Again, many propose that we don't rely on the grand theories. I asked you last week if nursing theory is dead, and there's some who think we need to move in different directions. Some say we should utilize NANDA, NIC, and NOC and develop theory from there. But as I told you, I haven't really seen a lot of movement in that direction. But many others believe we need to develop middle range theories using a variety of different methods and use them more in practice. And here are the references for that. And that's all. I look forward to seeing my group in class and hope you enjoy what we're going to be doing. Oh, one more thing. So when you come for the presentations, we will put up on the board the order, and you can sign up for the order you want to speak. When you come, be sure to bring your evaluation sheet and your handouts. If you have any questions on that or anything else, bring the questions to class.